20 milliseconds for PCI capillary. And opportunity we have the MSE renderation with dual energy, dual sources. We have the spatial resolution about 83 milliseconds and the temporal resolution about 0.4 millimeter. That adapt any quality for MSCD. And the second answer that between the speed and volume of watch we have here with the ECD with extra system, and we should do speed approach to have many overlap and a good image, and volume approach with many image select with any change of ECD cycle. And the first, optimize temporal resolution. The diastolic region vary by heart rate, and desired temporal resolution for cardiac CD about 250 milliseconds. We see here for the curve from 500 milliseconds to lowest 100 milliseconds, and the ideal the time is 200 milliseconds for trigger of exhibition. And nowadays we have a new generation from 1 to 5 slide CD in over 640 slide. We can reduce the speed rotation about 0.35. That's enough to have the quality of image very well. And the plum, the half scan reconstruction, and combined with prospective or retrospective visualizing. For a half reconstruction with faster quality. For example, here we see with one segment, which is not clearly an antibody. And for the half reconstruction with 0.7 second, 76 BPM with two segments, we can see clearly the LED here, clearly not a defect here. And the prospective is the gating curve should be have a 4 required stable heart rate under 65 BPM, cooperation patient good, and stable heart rate on each breath-hold. And we have the heart rate depend the BPM 65 to 72 to upper 72. The range from 65 to 80%. And retrospective rating, we have also with the cooperation patient and needing for stable heart rate on breath-hold. And important, we can do with the heart rate from 65 to 120 BPM. And the heart scan in all phase per circle. Breath-hold important about 7 to 12 seconds. Retrospective selection, you choose the best phase for reconstruction viewing, and the duration dose about 10 to 12 millisievert. And also the both prospective and retrospective retrospective rating have advantage or disadvantage. Advantage of prospective rating important for low dose and fast processing if the heart rate under 65 BPM. And for retrospective rating, on to high rating dose, but many advantages, which scan through the entire heart within ECG cycle, image goes after scanning, and potential. Continuously, these exit resolution, and we can see clearly the wall, the lumen of artery coronary, as well as about heart rate. And order velocity of each artery about 60 to 80 millimeters per second. We choose an artery about 40 to 70, but depend the branch of coronary artery, ASCI, LED, or circumflex can change about 40 to 50 to 60 are not interval. And here we can see that the range we can change to attain the high quality. The next problem is patient preparation. It's very important is the keys of optimal image quality. Ideal under 65 ppm. If we can use pharmacologic control, beta blocker, or calcium channel blocker, but for the risk of asthma, COPD, etc., should be indication which effectively. There is some evaluation is irrigating possibly fail if the heart is not regular. And the serum creatinine, which is GFR, upper 60, very important. Now we see here for the curve many waves, but under 60 BPM, very stable, very important for the best quality. But here, for the interval, about 50 to 70, that's the no movement of diastole of the heart. That's why we can use the beta block or not if we have upper 65 BPM, which filled by oral or by injection. And we should be controlled HR if not regularly. Important that's for instruction. And because of accelerate HR, because the patient always nervous, and reduce the drugs, nitroglycerin, terpentine, to regulate the heart rate, it should be cause of accelerate HR. And beginning of inspiration, we can have a little bit of movement. FD, time too long. It should be patient respirate, that effect of unit. And contract agent plus with warm in the body, if we have without warning for patient before, that's the problem. And we have also some patient with idiopathic tachycardia. And contrast media delivery and optimal coronary density. That's important. With the desired degree of arterial enhancement, about 300 to 350 HU. If under 200 HU, we can have an inadequate visualization of the artery coronary. Upper 350 HU can make distinction of lumen from moral classification and difficult or not exact or underestimate stenosis. If upper 100 HU luminous stimulation with non-calcification black very difficult to see and black as well. Otherwise, upper 500 HU decrease black detectively. For example, here we can see clearly, but here allow the contrast to nose and for the black calcification here, not detect stenosis here. And the fourth radiation exposure consideration, which a retrospective acquisition should be conducted with is related to current modulation. If possible, if held to be reduced, radiation dose about 30 to 50% radiation dose compared with without this modulation. Here we can confirm that with ECD and the TCDA with 120 kV, no ECD getting pulsing. We have the radiation dose about 25 decibel. But here, with standard ECD pulsing, the same kV, but we will use about only 15 millisieverts. And radiance dose here, for example, with 100 kV and perspective is rating, we have only 1.4 millisieverts here, but the image is clearly here. And the cardinal rules for radiation exposure consideration, keep always easily monitor far away from gantry as possible, and keep elbow straight with no flexion, keep the hand of the gantry, keep the angle of shoulder between 19 to 120 degrees to prevent subtractive pins that made the movement of patient. And important is stand posture at the beginning, at the room, private, anxious, and good cooperation. And here we have the curve, the elevated current modulation can reduce radiation dose of 30 to 50%. Important for radiation exposure consideration. And finally, check compound. We have here in the E, R, and R phase, the person on a time about 40-70%. If I can state and under 60 ppm, perspective is waiting now. Also, the perspective is waiting with 5% dose. But with the ECD based Q current modulation, we can reduce dose over 30 to 50%, and optimal current density at about 200 to 350 HU. Thank you for your attention. Thank you, Tiffany.
Thank you for Professor Roy for your excellent lecture. The next topic will be coronary artery anomaly by Professor Chung Im Chung. Currently she is a professor of radiology at the Seoul St. Mary's Hospital, the Catholic University of Korea. Her specialty is cardiovascular and thoracic imaging. Now she is a president of Korean Society of Cardiovascular Imaging and the Korean Study Group of the Cardiac MR. She is also the Assistant Secretary General of Administration Office of Asian Society of Cardiovascular Imaging, ASCI. And now she is Editor-in-Chief of the Journal of the Korean Society of Radiology. Professor Chung, please.
Good afternoon, ladies and gentlemen. My topic today is coronary anomalies. Contents are as follows: myocardial breathing, spectrum of anomalous coronary artery in relation to their origin and cause, coronary fistula. First, myocardial breathing. Myocardial breathing is the most frequently noted variant intramuscular course of coronary artery for variable lengths. It is most commonly localized in middle AD, but can occur in other segments as well. Prevalence of myocardial breathing is reported up to 42% at autopsy, whereas 6% at CAG. With the CT, prevalence of myocardial breathing has much increased, up to 44%. Although the segment of coronary artery is narrowed during systole on CAG and CT, it is very rarely clinically significant because most coronary blood flow occurs in diastole. However, atypical angina may be presenting symptom of myocardial breathing, and its mechanism is explained as follows. First, basic systolic compression of the artery produces a persistent mid to late diastolic reduction in coronary artery diameter, especially in tachycardic condition. Second, milking may produce systolic retrograde flow and overall flow disruption with augmented shear stress. Third, myocardial breathing has been related with coronary endothelial dysfunction that is an early stage of atherosclerosis and is associated with spasm, symptoms, and adverse events. Let's move on to spectrum of anomalous coronary artery in relation to their origin and cause. Coronary anomaly is common with quite different prevalence. This variability is probably due to referral bias and definition of anomalies and normal variant. It is increasingly recognized by cardiac imaging, especially cardiac CT. This diagram shortly explains the development of various kinds of coronary artery anomalies. Initially, a peritruncal capillary plexus is present and it makes blind-ended vessels which grows toward the aorta. It reaches aorta wall and creates the connections. If there are any mistake in those steps, coronary artery anomalies could develop. Coronary artery anomalies are classified as follows: anomalies of origin, anomalies of cause, anomalies of termination. Of these are potentially dangerous coronary anomalies which may induce ischemia. I will discuss these anomalies. First, anomalous origin of the coronary artery arising from the opposite sinus occurs. Left occurs is that left coronary artery originates from the right coronary sinus, and right occurs is that right coronary originates from the left coronary sinus. It is increasingly recognized by cardiac CT. The prevalence of occurs on CTA was 1.7% and approximately half of the cases were discovered distantly. It has variable presentations ranging from benign incidental findings to sudden cardiac death. There are many synonyms of a cause like that. It is a little bit busy slide. Observed prevalence of a cause on invasive coronary angiography is 0.44%, whereas prevalence of a cause on CTA is 0.87%. Prevalence of right cause is 10 times more than left cause in this report. In real world, left cause seems to be more rarely observed. A cause has 5 potential pathways from opposite sinus to normal course: pre-pulmonary, interarterial, subpulmonary, retro-aortic, and retrocardiac. Among them, pre-pulmonary, retro-aortic, and retrocardiac pathway are clinically benign. Interarterial and subpulmonary pathways are controversial. Classically, subpulmonary pathway is considered to be a low interarterial cause, which means that anomalous coronary artery originating from the aorta below the level of pulmonary valve. So both of them are caused with interarterial cause. Clinical importance of interarterial cause is that a cause has potential risk of sudden cardiac death. This paper with autopsy cases reported that left cause is associated with sudden cardiac death related to exercise. Suggested mechanism is that with increased expansion of aorta during exercise, it is possible the already slit-like opening of left coronary artery is actually occluded by a plug-like close of the orifice. Meta-analysis of cause reveals that sudden cardiac death of left cause is approximately 60%, whereas sudden cardiac death of right cause is 23%. Sudden cardiac death of right cause can occur, although the prevalence is lower than that of left cause. Possible mechanism for coronary flow restriction of right cause is as follows. Cell-like orifice, acute takeoff angle, low intramural course, compression by the aortic commissure, and compression between pulmonary artery and aorta. This case showed the narrowing of ASCI, orifice, acute angle, and the low intramural course. In addition, another mechanism of flow restriction is suggested by Lee et al. In high tide, anomalous ASCI ostium is located between aorta and the pulmonary artery. During systole, simultaneous distension of aorta and the pulmonary artery occurs and anomalous ASCI is compressed. In contrary to high tide, lower interarterial course show ASCI ostium located between aorta and right ventricular outflow tract. During systole, the aorta distends, but the alveoli contracts. Hence, the ASCI ostium is less compressed. A high type of interarterial course is related with high prevalence of typical angina and MACE. How should we manage a cause? Guidelines suggest that revascularization is recommended for interarterial left cause. For right cause, revascularization is recommended if there is an evidence of myocardial ischemia. However, there is knowledge gap in a cause patient. Incidentally found occurs is increasing with cardiac CT. However, mortality rate of occurs is very low in general population study. Occurs shows very low positive rate in stress test. So still we don't know what is the absolute risk of sudden cardiac death associated with occurs, and further study is needed. Second dangerous origin anomaly is Al-Kappa, anomalous origin of the left coronary artery from the pulmonary artery. More than 90% of patients die in infancy. Most dangerous coronary artery anomaly. Few survive to reach adult. Survival factor of Al-Kappa to reach adulthood are abundant collaterals between right coronary artery and left coronary artery, right coronary artery dominance, minimal coronary artery strip from pulmonary artery, and the systemic blood supply to left coronary artery. Here is the example. Left coronary artery arises from the main pulmonary artery, medial aspect, and coursing through the interventricular septum. Note the right coronary artery, large right coronary artery, and many collaterals. The Mendel image clearly demonstrates the large tortoise right coronary artery and collaterals. They fill the left coronary artery. Right coronary artery angiography shows a retrograde filling of left coronary artery and pulmonary trunk. MRI with dual enhancement shows diffuse subendocardial enhancement suggesting diffuse subendocardial infarction. The next dangerous origin anomaly is single coronary artery. Sudden cardiac death is more frequent in right single coronary artery. Hypoplastic coronary artery is associated with sudden cardiac death. Let's move on to cause anomaly, dual LAD. Dual LAD consists of short LAD. It ends high in the anterior interventricular groove, and long LAD, that most commonly originates as an early branch of the LAD proper, and rarely originates anomalous from the right coronary artery. There are 4 types of dual LAD. Of them, this type is most common. Short LAD and the large diagonal artery crossing distal interventricular groove. This is a rare case of dual LAD. Short LAD originates from the left main coronary artery, and it terminates high in anterior interventricular groove. Here is the relatively large diagonal artery. Long LAD originates from the right sinus of Valsalva and following interarterial course and enters anterior interventricular groove. Blue rendered image clearly demonstrates dual LAD type. Long LAD originates from the ASCI and distally enters the anterior interventricular groove, and left LAD is short, terminates high anterior interventricular groove. Let's move on to the last anomaly, anomalies of termination, coronary artery fistula. Coronary artery fistula is abnormal communication between the coronary artery and the cardiac chamber or great vessels. It occurs congenitally or it can be acquired. Prevalence of CAZ is this, and the most common drainage sites are cardiac chambers. However, incidentally found coronary artery fistula has increased after introducing cardiac CT. Presenting symptoms are non-specific, chest pain, palpitation, dyspnea, syncope, and etc. With cardiac CT, coronary pulmonary artery fistula is most common fistula. Here is the example. There is a vascular network at pre-pulmonary space supplied by both the coronary arteries and the drained pulmonary trunk. Typical coronary to pulmonary artery fistula. It is associated with aneurysmal dilatation. Other types of fistula can be found on CCT, coronary to bronchial artery fistula. It is frequently associated with chronic lung disease. And coronary to airway chamber fistula. Among various coronary fistulas, coronary to pulmonary artery fistula is important because it is the most common type of coronary artery fistula on cardiac CT. However, data about clinical significance of incidentally diagnosed CPAF is rare. Most are asymptomatic, and the most frequent symptom is chest pain, and it's difficult to discriminate whether it is ischemic symptom related with the coronary fistula or not. Although it is rare, severe complication of CPAF is reported. Here is the example. Patient was presented with hemopericardium after falling down, and imaging study revealed that coronary to pulmonary artery fistula with large aneurysm. Rupture of aneurysmal sac is suggested. Operation confirmed coronary to pulmonary artery fistula and aneurysmal rupture. CPAF can be treated with surgical ligation. And with transcatheter intervention, coembolization can be done. However, we don't know how should we manage CPAF. Because surgical ligation has a risk of myocardial infarction, we carefully select the patient for intervention. Indication for intervention is the history of ischemia, large shunt more than 30%, correlation of pulmonary hypertension or congestive heart failure, secular aneurysm. How do we identify a CPAF with ischemia? Early myocardial perfusion SPECT might be useful for determining the high hemodynamic status and for risk stratification in patients with CPAF. If the coronary artery still phenomenon is present, surgical treatment can be considered. We investigate the natural history of incidentally found CPAF and the proposed management strategy. Retrospectively reviewed 131 patients with a follow-up more than 2 years. Among them, 8 patients treated with surgical ligation, and the rest of them were treated with optimal medical therapy. In this study, there is no MACE related with CPAF. So the natural course of CPAF detected by CCTA is usually benign. Optimal medical therapy is enough. Interestingly, not ischemic symptom, but fistula size might be a real-world determinant for surgical treatment. We reviewed all the cases, myocardial breathing, spectrum of anomalous coronary artery in relation to their origin and cause, coronary fistula. In conclusion, knowledge of coronary artery anomaly is important because the number of incidentally found coronary artery anomaly on cardiac CT have increased. We should know the clinical significance of each coronary artery anomaly. We can provide the information of potential risk of sudden cardiac deaths with anomalous coronary artery arising from the opposite sinus. Thank you. Oh, sorry. Thank you for listening. And then let's move on to the next topic, atherosclerotic vulnerable plaque current perspective, presented by Dr. Unju Jeon. She is current professor of Seoul National University Bundang Hospital. She is very excellent and active researcher, published more than 100 ASCI journals, and then now she is working as chair of Society of Korean Cardiovascular MR Imaging Committee. Dr. John, please.
Thank you for kind introduction, Mr. Chairman. Good evening, everyone. My name is Unju Jeon from Seoul National University Bundang Hospital. I'm really honored to be here and participating in this wonderful conference. Because of COVID-19, I couldn't lecture on the ground, and I'm sorry to have lectured on VOD like this. Today, I'd like to talk about atherosclerotic vulnerable plaque current perspectives. My topic is divided into 4 sections. First, pathophysiology of atherosclerosis. Second, the definition of vulnerable plaque. Third, vulnerable plaque characteristics on CT. The last, challenge of plaque evaluation on CT. First of all, I'd like to talk about pathophysiology of atherosclerosis. Atherosclerosis involving the coronary arteries is critical because it is associated with the development of acute coronary syndrome and sudden cardiac death. The degree of stenosis is an important predictor for the cardiac events. However, it is possible that even a low-grade stenosis in coronary artery can lead to the development of acute coronary syndrome. In this regard, plaque structure and composition may be key to predict the development of future cardiovascular events. Then, why evaluating luminous stenosis alone is insufficient? Atherosclerosis is arterial response to injury. Atherosclerosis is a disease of arterial wall disease, not lumen. In early stages, the diseased adventitia can compensate for large carotid plaque by outward expansion of the vessel wall. Therefore, there is no luminous stenosis until more than 40% of internal elastic lamina. Therefore, luminography gives no information regarding the plaque vulnerability. To understand the morphology of the plaque, it is necessary to know the cause of coronary atherosclerosis. Atherosclerosis is a chronic systemic inflammatory disease. Atherosclerosis lesion formation is complex and involves shear stress, endothelial dysfunction, inflammation, neovascularization, and thrombosis. There is the illustration that shows the progress of the atherosclerosis. If the arterial damage is start, macrophage and foam cell are scattered, and early atherosclerotic change is formed as intimal fatty streak by the foamy macrophage. Then, the lipid-rod smooth muscle cells and collagens accumulate into that and become pathologic atheroma. As the necrotic core of atheroma gradually enlarged, it is captured by thin fibrous cap. It is defined as vulnerable plaque, and it ruptures through fissure or erosion, resulting in thrombus. This atherosclerotic change is a non-linear progress. Some atherosclerosis can be rupture, or some lesions can healing lead to stable lesions. Therefore, atherosclerotic change shows various and dynamic cause. In general, CT angiography can be evaluated from the pathologic atheroma, while IVUS or OCT can be evaluated from the earliest phases of plaque formation. Of course, invasive coronary angiography can only be evaluated if lumen stenosis has occurred. Then, what is vulnerable plaque? The vulnerable plaque is defined as a plaque has a high likelihood to cause thrombotic complications. Plaque that tends to progress rapidly is also considered to be vulnerable. This is the illustration that shows the various degree of luminal narrowing may be related to the repeated layering of repeated healing lymphocytes. As you can see, there are various types of vulnerable plaque such as thin cap, fibroadenoma, large lipid core, or intraplaque hemorrhage or calcified nodules. This is the criteria defining vulnerable atherosclerotic plaque. Active inflammation can be evaluated by PET. Thin cap fibroadenoma can be evaluated by optical coherent tomography. Intraplaque hemorrhage can be evaluated by MRI, while large plaque and lipid core and positive remodeling can be evaluated by IVUS or CT. Pathologically, the vulnerable plaque means a large necrotic core with thin cap fibroadenoma and macrophage infiltration. In virtual histology IVUS, vulnerable plaque is defined as plaque adenoma volume is more than 40% and containing necrotic core more than 10% of total plaque area. In optical coherent tomography, when a thin cap fibroadenoma of less than 65 micrometer is observed, it can be called a vulnerable plaque. Among the current medical imaging, the spatial resolution of OCT is the highest as 10 to 40 micrometer. It has known to be a unique imaging modality for the detection of thin cap fibroadenoma. Next, what is the characteristics of vulnerable plaque on coronary CT angiography? When evaluating a coronary lesion with the CT, we usually initially analyze the stenosis. The stenosis is measured at the maximal stenotic site and comparing it to the reference site, which is the mean value of the proximal and distal lumen sites. In the recently introduced CADRAS, standardized reporting system of coronary CT, the grade was classified according to the stenosis degree as shown in this slide. The goal of CADRAS is to suggest appropriate treatment accordingly to this system so that ultimately the quality of treatment can be improved. In these CADRAD systems, vulnerable plaque is recommended when the presence of two or more high-risk features by CT angiography as follows: low attenuation plaque, positive remodeling, spot calcification, or napkin ring sign. Therefore, we should understand the CT characteristics of these vulnerable plaque on CT angiography. Traditionally, the plaque on CT imaging has been classified into calcified, mixed, and non-calcified plaque based on whether the presence of calcium. However, recently plaque composition has some difference between acute coronary syndrome and stable angina, so there is an attempt to further subdivide non-calcified plaque into fibrous plaque and lipid-rich plaque. In addition, spot calcification has different risk and should be distinguished from calcified plaque. The evaluation of the remodeling index and plaque morphology, such as the napkin ring sign, also should be needed. This is one of the initial reports that suggests the potential merit of coronary CT angiography as a predictor of acute coronary syndrome. In this report, the patients who have both low attenuation plaque and positive remodeling have a higher risk for acute coronary syndrome when compared with the patients having one of feature or no features. Low attenuation plaque was defined as less than 30 Hounsfield unit, and positive remodeling was defined as more than 1.1. What we needed to notice here is that the tube voltage used in this study is 135 kV, not usually used 120 kV. So the definition of low attenuation plug also differs from study to study, with the House-filled units ranging from 30 to 60, although most studies have used 30 House-filled unit as a cutoff. Let me show you the similar case. A 49-year-old male patient visited the emergency department due to chest pain. At the time, cardiac enzyme is elevated and ECG shows ST elevation. Therefore, he underwent invasive angiography immediately and finally diagnosed as myocardial infarction due to occlusion of RCA. But he had taken coronary CT for health screening 2 years ago. On CT at the time, you can see mild stenosis with the low attenuation plaque with the positive remodeling. The average density of low attenuation plaque is 37 House-filled unit. Therefore, we can see that lesion with both low attenuation plaque and positive remodeling evolved into acute coronary syndrome over time. The remodeling index was defined as the ratio of the outer wall diameter of the region compared to the normal coronary outer wall diameter. Some experts favor measurement of positive remodeling index using vascular area rather than the lesion diameter because the area assessment has less inter-observer and intra-observer variability. Usually, positive remodeling means vulnerable plaque. On the contrary, negative remodeling is also represented coronary spasm as well as chronic fibrous plaque. Let me show you the case of showing negative remodeling of coronary artery on CT angiography in patients with vasospastic angina. A 57-year-old male performed cardiac CT due to acute chest pain. Coronary CT angiography with the showed axis image and curved multiplanar images showed diffuse concentric narrowing of LAD with minimal non-calcified plaque. Invasive angiography shows that initially normal LAD is narrowed after the algonobin provocation. It is completely resolved following nitroglycerin injection, so vasospastic angina was confirmed. Coronary CT angiography performed 4 months later for recurrent chest pain showed normal coronary vessels without discernible luminal narrowing. In this case, we confirmed the reversibility of coronary spasm on serial CT images. Napkin ring sign is also a typical CT imaging feature that represents the vulnerable plaque. In the CT image, the plaque with the low attenuation center surrounded by a limb of higher attenuation was defined as a napkin ring sign. Low attenuation center may means necrotic core. Peripheral high attenuation may caused by macrophage infiltration, vasovasorum proliferation, or spastic calcification. In comparison study between coronary CT angiography and optical coherence tomography, napkin ring sign is correlated with the thin cap fibroateroma on OCT. The napkin ring sign represents vulnerable plaque because it was more frequently observed in patients with the acute coronary syndrome than stable angina, although the sign had a limited sensitivity of 41%. Generally, coronary calcification is highly associated with the plaque burden and related to poor clinical prognosis. However, the effect of calcification on plaque instability is controversial. The calcification of the plaque was divided into 1 mm, 3 mm, and 5 mm. As a result, small spot calcification of less than 1 mm was associated with the SYNCAP fibroadenoma in virtual histology IVs. However, there are several challenges in the evaluation of the plaque on CT. First, CT has technical limitation. Although the temporal and spatial resolution of CT gradually increase with the technical development, there is still not enough for real cardiac imaging. Therefore, limited temporal and spatial resolution could affect the interpretation of plaque imaging. As you can see, motion artifact can misinterpret the type or characteristics of the plaque. The limited spatial resolution has more impact on plaque interpretation. With the large voxel volume in relation to the vessel size, averaging artifacts occur. Therefore, the blooming artifact of calcified plaque is more prominent in small diameter, such as coronary arteries, than large diameter, such as carotid arteries or aorta. Due to this averaging artifact, calcified plaque is usually overestimated and lipid-rich plaque tends to be underestimated. Various contrast agent-related factors also affect plaque imaging. Depending on the presence or absence of the contrast agent, the same non-calcified plaque show different house-filled unit density. In the non-contrast image, the plaque density measuring 25 house-filled unit has changed as 60 house-filled unit after the contrast injection. Even with the same contrast imaging, as the slice thickness increased, the CT attenuation is also increased. The plaque density also depends on the tube factor. Nowadays, with the development of CT technology, cardiac CT is obtained with the low radiation technique using low kilovoltage. As tube voltage decreased, house-filled unit density increased, noise is higher, and blooming artifacts are aggravated. As you can see, the volume of calcified plaque is larger in low kilovoltage imaging than high kilovoltage imaging. The most important problem is that plaque components are overlap, making it impossible to clearly identify the plaque characteristics. As you can see from the IVUS imaging, the plaque components are heterogeneous. Therefore, CT images based on the house-filled unit density has limited ability to clearly characterize plaque components. Another challenge of CT-based vulnerable plaque is low positive predictive value. Despite the CT-based vulnerable plaque features presence having high sensitivity in cases of acute events, its positive predictive value is relatively low, as 20 to 40%. Culprit region is defined as the region which actually develops acute coronary syndrome. It is a different concept from vulnerable plaque. I will show you CT imaging of acute coronary syndrome patients. Coronary CT angiography shows near total occlusion with the low attenuation plaque and positive remodeling. Therefore, this region can be defined as vulnerable plaque. In addition, we can see the decreased myocardial density at the midventricular interoceptal wall in the LAD territory, indicating myocardial ischemia. Therefore, it can be seen that the culprit region is arising from the vulnerable plaque of LAD. My colleague and I compared the CT characteristics between culprit regions and vulnerable plaque. There was no difference in the prevalence of positive remodeling, napkin ring sign, and low attenuation plaque between culprit regions and vulnerable plaque. However, a majority of vulnerable plaque was associated with less than 50% of luminal stenosis, and total occlusion and myocardial hypoperfusion was significantly associated with the culprit lesion. Therefore, the role of myocardial ischemia imaging, such as myocardial CT perfusion, CT-FFR, or transluminal attenuation gradient imaging, is also expected to expand in the future. In conclusion, the utility of coronary CT angiography should be expanded beyond the determination of the extent of coronary stenosis to the identification and monitoring of vulnerable plaque, with the goal of improving patient outcomes. Nowadays, CT can provide useful information about the characteristics of vulnerable plaque. However, there is still a technical limitation for ideal plaque imaging. So, advancements in CT technology, improved spatial and temporal resolution, are mandatory to more precisely evaluate vulnerable plaque. In addition, there are some argument points for the determination of vulnerable plaque. Therefore, further comprehensive studies using novel techniques and pathology correlation should be needed. Thank you very much for your attention.
Thank you very much for Professor Woo Joo Chon for excellent lecture. The next topic will be MR coronary angiography by Professor Hajime Sakuma. He is a professor and chairman, Department of Radiology, Mia University Graduate School of Medicine, Deputy Director of Management, Mia University Hospital. He was the board of trustee Society of Cardiovascular MR during 2006 to 2010, and he was the president of Asian Society of Cardiovascular Imaging during 2017 to 2019. He got the first Gold Award from Asian Society of Cardiovascular Imaging in 2014, and he is a senior fellow in the International Society of Magnetic Resonance in Medicine in 2015. He has more than 200 papers in peer-reviewed journals in English, and he is a pioneer in MR coronary angiography. And now he is going to have a talk with MR coronary angiography. Professor Sakuma, please.
Hi, it is really my great pleasure to talk about coronary MR angiography. Okay, so can you see my presentation? Okay.
Yes.
Okay, thank you. So the coronary MRI has a history of over 30 years. That is actually longer than the history of cardiac CT. And the images on the slide shows a 2D gradient echo coronary MRI acquired in early 90s. And today, as you know, the image quality and the diagnostic performance of coronary MR angiography has been considerably improved. However, compared to the CT, the acquisition of coronary MRI is still complex and not widely used compared to the cardiac CT. Okay, and the coronary MRI has several important advantages compared to cardiac CT. So the advantages include no ionizing radiation and the feasibility of non-contrast study and insusceptibility to heavy coronary calcification. These images on this slide are sensory images of right coronary artery LMT, LAD, and circumflex by using a 3T free breathing whole heart coronary MRA. In this 60-year-old woman, she had effort angina and underwent coronary CT angiography using a dual source CT. However, due to heavy coronary calcification and the presence or absence of luminal narrowing in the proximal RCA and LAD is very difficult to evaluate. However, on 3T free breathing whole heart coronary MRA, there is no stenosis in the right coronary artery, and we found significant stenosis in the proximal LAD, including the proximal portion of diagonal branch, and that was confirmed by X-ray angiography. And this table summarizes the diagnostic performance of coronary MRA in multi-center studies. In a study using a gradient echo 1.5T target volume approach, the good sensitivity of 88% was reported, but specificity was quite limited, 58%. In a multi-center study performed in Japan, using a 1.5T SSFE whole heart approach, high sensitivity of 87% and moderate specificity of 71% were obtained. And a more recent study using a 3T double dose whole heart coronary MRA, a sensitivity of 90% and a specificity of 80% were reported. And in a meta-analysis study published in 2016, the diagnostic performance of contrast-enhanced MRA was significantly better than non-contrast enhanced studies. And as shown on your right, the diagnostic performance of whole heart coronary MRA was significantly better than the target volume approach. When 1.5T and 3T coronary MRA were compared, the sensitivity on the specificity of 3T MRA were 93% and 83%. So these values were better than those by 1.5T, but no statistical significance was observed. For the steady state acquisition and gradient echo acquisition, the sensitivity is actually better for gradient echo pulse sequence. And specificity was not significantly different. So this is probably related to the use of gradient echo pulse sequence at 3 Tesla. And there are several important points to obtain high quality coronary MRA. And the first point is respiratory gating and abdominal belt. So suppression of the respiratory motion is a major point. Because MR acquisition of the high resolution coronary images covering the whole heart requires imaging time of several minutes. So respiratory gating or some kind of suppression techniques are very important. So this slide shows respiratory gating with a very traditional navigator echo approach. By monitoring the position of the right diaphragm, ECG-gated images data were acquired during the expiratory phase with a typical navigator gating efficiency of 30 to 60%. So self-gating approach is technically advanced, but basically there's not much difference in the image quality between a navigator echo approach and the self-gating approach. And the abdominal belt physically reduces the amount of respiratory motion, and we believe that is very important to improve image quality of coronary MRA. In a collaboration study between New University and King's College, we found that abdominal belt significantly reduced the difference between the end expiratory and end inspiratory position of the diaphragm. And this improves scan efficiency and also improves the image quality as shown on this slide. Because motion of the coronary artery in the cardiac cycle is different from patient to patient, image data should be acquired in an optimized acquisition window in the cardiac cycle in each patient that exhibit minimal motion of the coronary arteries. So this slide explains the patient-specific acquisition window explained in our first paper demonstrating the usefulness of whole heart coronary MRA in the ASCI. We first monitor the motion of the right coronary artery on the high temporal resolution Cine MRI. Typically, imaging data were acquired during diastole in patients with low heart rate and during systole in patients with high heart rate. So in early 20s, when the 20th century, in 2006, when this paper was published, we used the acquisition window of 98 milliseconds to 150 milliseconds. However, that temporal resolution was not enough. So after that study, we used a more narrower acquisition window in the cardiac cycle. This figure shows a relation between the acquisition window and the heart rate. In patients with a high heart rate, the acquisition window in the cardiac cycle needs to be shorter to reduce motion blurring of the coronary arteries. In patients with high heart rate, we use a narrow window of 50 milliseconds or lower, which is, we believe, very important to obtain high quality coronary MRA. This is an example of 3T whole heart coronary MRA acquired with these approaches explained in previous slides. Severe stenosis in the left circumflex artery was observed as shown with a red arrow. Notice that these MRI images were acquired with a temporal resolution of 53 milliseconds, and the imaging time was a little bit lengthy, 13 minutes. However, with this approach, 3T coronary MRA obtained after rate gathering enhancement demonstrated the sensitivity of 86% and specificity of 93%. So what about the sublingual nitrate and the beta blockers? Because of the spatial resolution of coronary MRA is generally limited, we always give sublingual nitrate to obtain the better visualization of the coronary stenosis. So what about beta blockers? Of course, we routinely use beta blockers for coronary CTA at New University Hospital. However, for the past 18 years, we do not use beta blockers for coronary MRA because in contrast to the cardiac CT, we can control the temporal resolution of the data acquisition in the cardiac cycle. So in patient with a high heart rate, we use narrow acquisition windows as we mentioned. And as shown in this table, we found no significant difference in the image quality between low heart rate group and high heart rate group. Of course, if the temporal resolution is relatively limited, then nitrate may give the difference. But we should notice that the temporal resolution can be controlled with MR imaging. So there are several limitations of coronary MRA, including the lengthy imaging time and the operator dependency. The acquisition of whole heart coronary MRA typically requires imaging time of 10 minutes or more. And as you know, by using the compressed sensing approach, imaging time can be substantially shortened. In this case, imaging time was 16 minutes without using a compressed sensing. And the use of the compressed sense with a factor of 8.25 reduced the imaging time to less than 6 minutes. And the image quality is generally preserved. And this slide shows the imaging time of 3T whole heart coronary MRA before introduction of compressed sense and after the introduction. And typically the imaging time was 11 to 12 minutes before introduction of compressed sensing. After introduction of the compressed sense, the imaging time was reduced to approximately 5 to 6 minutes. That is quite useful. However, we still have a problem of the operator dependency. This data was demonstrated by Matthias Tuber in Lausanne, and typically for the brain MRI, the technologist performed 20 to 30 mouse clicks for one study. In contrast, more than 130 mouse clicks were required to complete a whole heart coronary MRA examinations because the necessity of manually optimizing cardiac gating and respiratory navigators. In addition, image quality of coronary MRA is highly operator dependent. So, what is the future direction of coronary MR imaging? Certainly, the current technique of self-gating or navigator echo-gated whole heart coronary MRA approach is a little bit difficult to be used in every hospital. And recently, a totally different approach to handle respiratory motion and cardiac motion called XD grasp was introduced. In 4D respiratory motion resolved coronary MRA, XD grasp method was used to obtain 4D dataset, including 3D spatial dimensions, XYZ, in addition to the respiratory motion phase. As shown in this figure, ECG-gated image data were acquired with a golden angle radial sampling approach, and the respiratory motion signal was directly extracted from the imaging data. So this is a self-navigation, self-gating approach. And the data was sorted into 4 to 6 respiratory phases. So these multiple reformatted images obtained 4D respiratory motion resolved coronary MRA in a volunteer at Mie University Hospital without contrast injection. This approach was performed as a collaboration with Mathieu Stubers. So relatively good image quality were obtained with this approach. And this slide explains the concept of fully self-gated free-running 5D whole heart coronary MRA. 5D means 3 spatial dimensions plus respiratory phase plus cardiac phases. As demonstrated on your left, 3D golden angle radial sampling was continuously performed without ECG gating or respiratory gating. So the acquisition pulse sequence is pretty simple, just repeating the golden angle radial sampling. The data set was then firstly sorted to the different cardiac phases and further sorted to multiple respiratory phases in a post-processing. And the images at different cardiac phases at the selected end expiratory phase are displayed on your right-hand movies. CINE-MR images can be generated from 5D XD grasp dataset. And when the images at different respiratory phases at a certain cardiac phase are displayed, you can see a respiratory motion on the images on your right hand. And if 3D imaging data set at selected diastolic phase and at end expiratory phase, the 3D imaging data set can be shown as a CINE image, movie images on your right. So this data set corresponds to the ordinary 3D whole heart imaging data set. So this is a fully self-gated free-running 5D coronary MRA at 5 Tesla after by using a slow injection of gadolinium contrast medium. And because power sequence continuously repeated, the fat saturation should be optimized. So the Masaki Ishida is collaborating with Lausanne University, and he optimized Libre fat saturation approach. And you can see a right coronary artery, left circumflex artery, LAD, proximal, middle, and distal, with a relatively good image quality. So because no ECG or respiratory gating was employed, the operator only defined 3D volume dataset and just start the acquisition. However, reconstruction takes quite long time at this point, more than several hours, but we hope that artificial intelligence algorithm will dramatically reduce the imaging reconstruction time in near future. So CMR allows for the comprehensive assessment of cardiac function, myocardial perfusion, and tissue characterization, as you can see in this ASCI meeting. However, comprehensive CMR is still very complex and requires a considerable operator dependency. And the 5D grasp and other similar approach may cause a paradigm shift in cardiac MR because it can dramatically simplify CMR acquisition and high resolution coronary MRA at multiple cardiac phases. So And this also allows Shine MR acquisition in any arbitrary imaging plane. Can be obtained with a single click acquisition. Thank you so much for your kind attention.
Thank you, Dr. Professor Hajime Sakuna, your excellent lectures. It's very impressive. 4D and 5D MRA is very fantastic. Okay, we have all the lectures, so now we move to the Q&A session. I have one question, two questions from the audience, and then to Dr. Hongmin Roy. One is reserved. In daily practice, how many percentage of case then you can use prospective gating? And then Dr. Roy's answered that about 70% cases in his hospital. And then I think that it depends on the machine that we have. So if we have a more dual source CT with short temporal resolution, percentage of prospective gating is increasing, I guess. And then the next question is not answered by Dr. Hongmin Roy, and then is that for heart rate control in those with contraindication of beta blocker, any comment on these different drugs like Coraran, Verapamil, and Diltiazem? And then Dr. Lloyd answered that he has no experience, so please ask the answers from the panelists and other actors. So actually, we can in the text we can use the calcium channel blockers like that, but I have no experience with the calcium channel blocker. Usually, we use the beta blocker with beta 1 and beta 2 blockers. However, most contraindication is asthma beta 1. So we use the beta 1 selective blocker like short acting esmolol. I think for the patient with asthma patient, it is some resolution. And then for other contraindication like the severe atherosclerosis or third degree van der Branch block, we can use the calcium channel block. However, it is I think that we have a little experience about it because it has also some contraindications for the use. So I think that beta selective blocker is one answer, and then otherwise I have no experience. If there are some experience about that, please answer these questions of lecturers and moderator. Yeah.
Okay. I just a little comment for this question, because for the usual beta blocker which nitroglycerin nitrate sublingual. Okay, you hear me?
Yes, we can hear you. Yeah.
Okay. Hello. Because that depend the patient. If we have not control, you hear me?
Yes.
Not control the heart rate, we can support by clinical support, because we have not experience to use the drug for the decrease heart rate. That's why, because the condition for patient, any fundamental disease, etc., should be in the special case for the irregular heart rate, should be consulted by the clinical doctor. Thank you.
Okay. I have a short question to Dr. Hajime Sakuna. You told me that the beta blocker is not useful for is not useful for cardiac coronary MR angiography. How's the nitroglycerin? Nitroglycerin is a vasodilator, so we guess that it might be useful to dilate the coronary artery in coronary MR angiography.
Yes. The sublingual nitro spray is always used. And if we obtain the coronary MRA only, then beta blocker may be useful, but we usually use coronary MRA in addition to the CMR functional assessment. So if you use a beta blocker during the single cardiac MRI study, the reduction of the heart rate during the study is very complex. So that's one is if you only do the coronary MRI, maybe we use a beta blocker. But fortunately, as I mentioned, the acquisition window in the cardiac cycle can be shortened with MRI. That's why we do not use beta blocker in a cardiac MRA study.
Yeah, it's very helpful information. Yeah. I have a short question to Dr. John. I have one short question to Dr. John. You show the various kinds of vulnerable plaques, and then nowadays perivascular fat attenuation is one useful modality to predict the acute coronary syndrome. So how's your experience or opinion about that?
Yes, that's a good question. As you said, nowadays pericardial fat attenuation is very important to predict the future cardiovascular event. However, the measurement of the attenuation of pericardial fat is depending on various factors. Non-contrast enhancement or enhancement, the fat attenuation is different. Different before and after the contrast enhancement, and also the radiation factor and Q factor and other factors affecting the perivascular fat attenuation. It is like the plaque imaging. So I think but there is no standardization of pericardial fat attenuation until now. So I think the standardization of the pericardial fat attenuation or the protocol will be needed.
Yeah, will be evaluated and it will be helpful in the future.
Yes.
Yeah. Okay. I think the time is approaching, so Dr. Stipong Jongirashi, could you close this session?
Okay, thank you, Professor Jung. I would like to thank you, our speaker, including Professor Lloyd, Professor John, Professor Sakuma, and also my co-chair, Professor Jung. And now I would like to close this section. Thank you very much and have a nice day. Thank you.
Thank you. Thank you very much.
Thank you.
And his team.
Great lectures. Great lectures. I really
with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.